Hello everyone, Professor Sharma here. So in my lecture today I'm going to discussing about stereotactic body radiation therapy that I will call SBRT. Okay, so I think at the end of this lecture you will definitely appreciate why many people consider SBRT because it almost like doing surgery without a scalpel. So this is very important thing. So the question again is if I want to deliver extremely high dose of radiation to a tumor in just 1 to 5 fractionation, but still it can spare the normal tissue, that exactly what SBRT allows us to do. So what exactly is SBRT? In my previous lecture I talked about the SRT, right? I talk about the IMRT, I talk about the 3D conformal radiation therapy. So what exactly is the SBRT? So that's what I'm going to discuss in this lecture. So in simple term, SBRT is the technique again in modern radiation oncology where we deliver the very high dose of radiation with extremely high precision to tumor located outside the brain. Remember that we deliver the radiation outside of the brain, not the cranial region, outside the region that we call the extracranial region. So typically in just a few fraction we give 1 to 5, depending on the situation we give just few fraction. So the word stereotactic refers to the three-dimensional coordinate system I discussed in my previous lecture. Basically we know exactly where the tumor is in this space. So think of this like a GPS. Okay, so GPS is used to find a very small target, right, locations. So but instead of the delivering a food, we are delivering the radiation here. Okay, much higher stakes here. So delivering a food, you don't have, if you don't find the exact location, you might miss a location. But in delivering the radiation, you have to target exact locations to spare the normal tissue to get the maximum effect. Now let me ask another question here. So the how many you have studied the SRT, that we call the stereotactic radiotherapy? So here is the key distinction between the SRT and SBRT. So the SRT is used in the brain, right? SBRT is used in the body, outside the brain. But the real difference is not just the location, it is the complexity. What's the difference in complexity between SRT and SBRT? Because in the brain, right, things don't move much. But in the body, for example in lungs, maybe liver, pancreas, right, everything is moving all the time. Breathing, digestions. A tumor is basically going to a daily workout routine, you can say that. Okay, so here is something to think about. Okay, if the tumor is moving, how do you hit it accurately with millimeter level precision? Right, you are giving the radiation to the lung, you are giving the radiation to the pancreas or the liver, things are moving here. Okay, keep this question in your mind. So we'll come to that when we talk about the motion management, because motion management is very used topics in SBRT. Okay, so let me talk a little bit about the dose. Okay, so in conventional radiation therapy we usually deliver around 2 gray per fractions over the several weeks. Okay, but in SBRT we are talking about 6, 10, 15, even 20 to 25 gray per fractions. That's the huge, right? That's the huge radiation amount. So let me ask this: why don't we give this high dose everywhere and finish treatment in one day? Even we are giving in the fractions, we are giving the high dose, but in fraction. Why we are not giving in one day? So radiobiological effect here. So I discuss in many times in my lectures, previous lecture. Okay. So it sounds efficient. So giving all the radiation in one day sounds efficient, right? I know some of you are smiling here. Okay, I can imagine that. The answer, of course, is normal tissue toxicity. So without precision, this would be extremely dangerous. If the normal tissue toxicated by the radiation, we are harming more than helping the patients. So keep this in mind. So that brings us one of the most beautiful aspect of SBRT that we call the dose conformity. Okay, remember this term, dose conformity. Imagine shining the multiple flashlight from different direction onto a single point. Okay, I'm giving a very simple explanation here. Okay, imagine you are shining the multiple flashlight from the different directions onto the single point. So the each flashlight alone is not too intense, you know that, but where they all intersect, the light becomes very bright. That's essentially how early SBRT work, using circular beams or cones. Totally totally very different idea at that time. Okay, so today we have much more advanced tools like IMRT and BMAP, where the beam shape dynamically changes, almost like sculpting the dose around the tumor. Let me pause here. So let me pause here and ask you a brainstorming kind of question. Okay, so what do you think is more important in SBRT, high dose or high precision? What do you think? You want high dose or high precision? What do you want? High precision. The answer is the high precision. Definitely you will choose high precision. Okay, so without the precision, high dose becomes the problem instead of a solution. Remember that. Okay, instead of the precision, high dose becomes problem rather than the solution. So precision is very important thing here. So now where do we actually use SBRT? What do we use? Okay, it is widely used in the lung cancer, lung tumor, liver metastasis, maybe the spine lesions, pancreatic tumors, kidney tumors, and even prostate cancer in selected cases. Not all, some selected prostate case we use SBRT. Okay, especially in patient who cannot undergo the surgery. So the SBRT becomes so powerful. Okay, so powerful alternative. In early stage of the lung cancer, SBRT can achieve local control rates comparable to the surgery. If we find the lung cancer early, use the SBRT technique, we can get the same procedure like a surgery. That's incredible thing to imagine. Okay, so that's why people often say it is like a virtual surgery, and say that the SBRT is like a virtual surgery. Now let's talk about the tumor size. Okay, let's talk about tumor size. So typically the SBRT works best for the tumors less than the 5 centimeters. Okay, so let me ask, what do you think larger tumor are harder to treat like SBRT? Why? What do you think that? Think about it. Okay, so the larger tumors means larger high dose region. Okay, so which increases the risk of surrounding organ. Okay, large space means a large risk there. So again, we are limited not by our ability to deliver the dose, but our responsibility to protect the normal tissue. Remember that. As the clinician, your role is not to deliver the dose, but at the same time, your responsibility to spare the normal tissue. You try to avoid any kind of the toxication from the radiation, okay, radiation harm. So let's shift a little bit of the gear, okay, let's shift the gear a little bit here. So talk about the radiobiology, because radiobiology is very important point to talk about here. Now I know this is the part where some of you start to worry, okay, when I say the radiobiology, you start to worry about that, but don't worry, we will keep it intuitive, okay, I will keep this in intuitive. So SBRT delivers a very high biological effective dose. I'm saying that it is not only deliver the dose, it is deliver the very high biological effective dose, okay. So which we call the BED, right? You know that BED, biological effective dose, okay. So let me ask you, what happens when we deliver very high dose per fraction? So let's come to that question, okay. Yes, greater tumor shall kill, okay, greater dose, it kills the greater amount of the tumor, okay. But also something interesting happens here, okay. We can damage the tumor blood vessels and even stimulate the immune responses here, okay, because we damage these tumor vessels, blood vessels, we stimulate the immune response. So SBRT is not just physically precise, it is biologically powerful, because immune response is also a triggering here. So that's quite interesting thing, right? That's quite interesting. So the first step for the SBRT is the simulation again, okay. This is where we acquire the CT, MRI or PET, okay, image. So let me ask, why do you need all three sometimes, okay? You want CT, you want MRI, you want PET. Isn't CT enough? Why CT isn't enough? So you know the CT needed, right? CT gives the anatomy and electron density. So to deliver the exact dose, we need the electron density. So that's we discussed from very beginning, okay. So the MRI gives the better soft tissue contrast, and the PET shows the metabolic activity, okay. So when we combine all of them, we get a much clear picture of the tumor, okay. That's why we need all of them sometime. So and nowadays we have the PET CT, so we'll come to that topic. So the PET CT can even be done, PET and CT, in a single machine. You don't need to go to the PET machine, you don't go to CT, you can do both PET and CT nowadays in technology, okay. Very efficient and very accurate. So next step is the patient immobilization. So this sounds simple, but it's absolutely critical in stereotactic. So patient immobilization is the very important thing here. So let me ask you, if the patient moves even a few millimeters, what would happen, okay? What happens in SBRT? So can you guess it? So exactly, the high dose region may miss the tumor or hit the normal tissue, even the millimeter range of the motion of the patients. The wrong place can be hit by the dose. That's why motion management is very important thing, very critical thing. So very important thing here. So we use the vacuum cushions, maybe body frames, and whatever it takes to keep the patient still, we use. So that is the different topics. I'm not going to explain here. I discuss about the SRT techniques at that time. I discuss many about immobilization devices over there, okay. So sometime I tell students in SBRT, even a small movement can make a big difference. That's why take the immobilization process very important. So now comes to the very most important question here. Okay, now let's come to the very, very important part here, motion management. Okay, remember the question I asked earlier. So tumor moves, especially in lungs. So how do you deal with that when deliver the dose? So we use the several techniques. Okay, we use the several techniques in motion management. Okay, the motion management. So one is the 4D CT. Remember that the 4D CT techniques. Okay. So 4-dimensional CT. So what do you mean by that? That means image of the tumor across the breathing cycle. Okay. So what do you mean by that? In 4D CT, where we image the tumor across the breathing cycle. We're going to take the image. We take the image, inhale and exhale, both cycle. So another is defining the internal target volume. Remember that the ITB. ITB is very important. Internal target volume. Okay, that's very important thing. So why do that? Because in ITB includes all position of the tumor. Okay, so we can also use the respiratory gating. Okay, that is another technique we can use where the radiation is delivered only at a certain phase of breathing. Okay, you deliver the radiation while maybe inhaling the breath or exhaling the breath. Okay, so that we call the respiratory gating. Okay, so here is a fun one. So breathe hold techniques. So another is the breathe hold technique. So let me ask, have you ever been told to hold your breath during a scan if you take the scan? Okay, that's exactly what we use. So this inspiration, breath hold. The patient takes a deep breath and hold it. What it did is it reduces the motion and sometimes even moving critical organs away from the tumor. Okay, very, very clever, right? Very, very clever techniques. Breathe hold technique. Now the next comes to the treatment planning. Okay, that's the critical point here. So where is the physics really science here? I would say that. Okay, we contour the tumor, we contour the GTP, we contour the ITB, we contour the PTB, right? We design the beams using the IMRT or BMAT. So that's how physicist is very critical in radiation oncology field here. Okay, so the advanced algorithms like Monte Carlo, that we call the MC, which we calculate the dose, okay, accurately. So the why do you need such accurate dose calculation in SBRT? Because even small errors can have significant consequence at high dose region. Okay, if you give the high dose, a small error will have the detrimental effect. So that's why very, very accurate algorithm you need to use to calculate the dose. Not only the delivery, also calculation of the dose must be very, very accurate. Okay, so let me go a little bit further, a little bit with the image guidance here. Okay, image guidance we call the IGRT. Okay, IGRT. So I'll have a next lecture, one of the lecture in the surface guided radiation therapy. So I'll discuss about that in detail. Before the treatment, what we do is we verify the tumor position using the cone beam CT or other imaging technique. Not, you can take any other. So think of it like a double checking your GPS. Okay, double checking your GPS before making a critical turn. Okay, you don't want to end up with the wrong place. Okay, that's the thing, because that's why IGRT is very important thing. Okay, so finally, once it is verified, we deliver the treatment. Okay, we deliver the treatment usually in just a few seconds, a few sessions. Okay, very, very few sessions. Okay, short, it's precise and highly, highly effective. Okay, so let me ask you final reflective questions. Okay, so my question is this: if somebody as a patient, would that person would prefer the 30 treatment or the 3 treatments? So most people would say 3. Okay, but remember that you can choose the 3 fractions only instead of the 30 if it is safe and effective. That's why I'm saying safe and effective is 2 mantras here. Okay, so that's what exactly SBRT aims to achieve. It must be safe, it must be effective. Okay, so what are the advantages of SBRT? Okay, so it is non-invasive. Okay, it's the virtual surgery, so highly precise, and it has the excellent tumor control history. So, but it is not without the challenge. Remember that it has a lot of challenges also. So it requires expertise, it requires careful planning, it requires the strict quality assurance. Therefore, it is so costly. Okay, so let me wrap up. Let me wrap up with this thought here. So the SBRT represents the perfect combination of physics, biology, and the technology. I would say that. Okay, so it allows us to deliver the surgical level outcomes without actually performing the surgery. Okay, so as the technology continue to evolve and improve, okay, so AI, adaptive radiotherapy, real-time tracking, okay, lot of things. Okay, how far we can push the limit of the precision radiation therapy. So that's a critical thing. So I think we need to think a little bit about that, to get the surgical level outcomes more precision, more accurate. So how to use the adaptive therapy, how to use the artificial intelligence, how to use the real-time tracking. That's something as a future scientist or future clinician will help the answer. Okay, thank you very much. So if you have any questions, happy to take your questions.